Welcome to this podcast from the Medical Journal of Australia. My name is Sally Block, the MJA's news and online editor. Australia now has its first male infertility guidelines. The guidelines are featured today as an online first ahead of their official publication in the MJA later this year. The MJA acknowledges the traditional owners and custodians of the land on which we live and work across Australia. This podcast was recorded on the lands of the Gadigal people of the Eora Nation. I pay my respects to their elders past and present. Associate Professor Darren Katz is a urologist at the University of Melbourne's Department of Surgery. He is Medical Director of Men's Health Melbourne. He's here to speak to us about the guidelines and joins me now. So female infertility is the most well-known and most talked about. How about male infertility? What can you tell us about that?
So that is such an important question, Sally. I really do think that male infertility is an underappreciated issue. In Australia, infertility affects 1 in 6 couples, so it's very, very common. Male factor infertility is evident actually in 50% of the time. There is a contributing cause from the male. And it is actually the sole cause of infertility in 20 to 30% of those 1 in 6 couples. So it really is quite a common issue. I do believe it really is underappreciated, and it's so important that we're talking about it today.
So these are the first Australian-based guidelines on male infertility. What inspired the creation of them and why?
So it goes back more than a decade, Sally. In around 2011-12, after my training in urology, I spent some time in America doing subspecialty training at a place called Cornell or New York Presbyterian. It's a major male fertility center in New York. Whilst I was there, I realized that there are just so many advancements in male infertility that I didn't even know about or come across during my training here in Australia. So I brought some of these techniques, these operations and these approaches back to Australia for the treatment of male infertility back here in Australia. And I slowly began to try and sort of change the way that male infertility was managed in Australia. But the truth is, Sally, trying to change entrenched practices of doctors in medicine, no matter what the area of medicine, is notoriously difficult. And I think one of the main reasons why our approach to male infertility is different here in Australia, and by different I mean sort of a bit more fragmented and inconsistent when compared to places like the USA and Europe, is because in both of these continents, there are established evidence-based guidelines for medical practitioners on how to manage male infertility. These guidelines have been available for more than 2 decades now, and they are serially updated. But in Australia, there are no such guidelines. And so about 3 years ago, a panel of male infertility experts got together, and really I must do a big shout out to the 6 other members of the panel of experts, because without them, these guidelines would have never come to fruition, and it was a real team effort. And so we decided about 3 years ago to develop these first ever Australian-based guidelines on managing male infertility. And it is culminated in 80 guideline statements or recommendations, which are all evidence-based and rated accordingly. And because these are now being endorsed by key stakeholder organisations, such as the Urological Society of Australia and New Zealand, of which I'm a part because I'm a urologist, the Endocrinological Society of Australia and New Zealand, the Fertility Society of Australia and New Zealand, so that encompasses the IVF specialists as well, so the female side of things, as well as the organisation called Healthy Male, which is funded by the Australian Department of Health. And they are the ones that really provided a lot of the sort of background support and helped sort of lead the charge in this important endeavour. Because of all this, because of the background and because of the support of these organisations and their endorsement, I really think this is going to be a game changer in male infertility and how male infertility is managed in our country.
So just out of curiosity, is there anything that makes them uniquely Australian as opposed to, say, the European or US guidelines?
Yes, there are. There are several factors why these are uniquely Australian. Firstly, all members of the panel of experts were all Australian. Okay, we've all got a lot of experience in male infertility in Australia. Also, as I mentioned in the answer just before regarding this key stakeholder organisations, the Urological Society, the Endocrinological Society, the Fertility Society, they're all Australian organisations as well as Healthy Male. Another factor is that the papers we referenced, where possible, were referencing Australian studies. For example, there's an operation that was developed by my mentor in New York, who I trained with, Professor Peter Schlegel at Cornell. That's an operation called the microteasy. Just for your listeners, that's basically a complex microsurgical operation to try and find sperm in patients who have no sperm in the ejaculate. So trying to find sperm in the testicle using a high-power microscope, using live feedbacks from embryologists based in the operating theatre to try and find sperm somewhere in the testicle where in the ejaculate there was no sperm. So that's called a microteasy. It can take several hours. Now, that particular operation, in 2022, I produced the first Australian series of my experience with microteasy, and that was published. And that exact example of how we have used that paper was referenced in the guidelines. And so there are other papers such like that. They're using Australian-based data to help that we have referenced in the guidelines to make this very much an Australian flavour. Also, the methodology we have used in developing the guidelines was tailored to the Australian landscape. And what I mean by that is that, as we mentioned previously, there have been guidelines have existed in America and Europe for 20 years. But what we did is we used both of these guidelines, the American and the European guidelines, which were both very comprehensive, very evidence-based. For instance, the European guidelines were 130 pages and had 500 references. But what we did was we compared and contrasted both guidelines. We distilled and refined them for the Australian setting, and we took into considerations sort of regional differences. Medicare, certain tests may be funded here or not funded here, as they may be overseas. We took into account different ethnicities, and we took a very sort of pragmatic and user-friendly approach where we could. So these guidelines really are made up to the Australian setting, and we think they'll be very, very user-friendly to the Australian population and the Australian practitioners that are managing infertility.
As you said, there is a large predominance of male infertility in Australia. What are the causes?
So, look, the causes there's huge number of causes is the truth in male infertility. Unfortunately, probably one of the most common causes is unknown, i.e. idiopathic. So there are patients who come to see medical specialists to try and get an underlying cause. They have an issue with their fertility, and we do a whole gamut of tests, and sometimes we just don't find the cause. But sometimes we do. And I'll list some of the common ones. So a varicocele. A varicocele is varicose veins in the testicle. It's common. 15% of men have a varicocele, but it's only a minority of men for which that is clinically significant. And by clinically significant, we generally mean a varicocele that is palpable. And generally the larger ones are more significant. But we know that varicoceles are present in around a third of men who have what we call primary fertility. So they've never been able to conceive with their partner. And it's actually present in up to 80% of men who have what we call secondary fertility. So they've conceived, but they're having difficulty conceiving again. So a varicocele is a very important diagnosis in male infertility. And going to the point, out of the 80 guideline statements that we have, 80 recommendations, around 6 of them are purely on varicocele alone. And that's an important thing for your listeners to appreciate. There can be anatomical causes such as a blockage or obstruction. Quite a common reason for that might be patients who have had STDs. So gonorrhea and chlamydia can cause blockage, especially in the epididymis. It can be a cause of infertility for patients. Endocrine issues, such as testosterone abuse. So a lot of people don't appreciate this. So patients who take testosterone, especially high doses of testosterone, it actually is a poison to sperm. And so a lot of people don't appreciate that. So we see patients who, for instance, bodybuilders who take testosterone not under medical supervision. A lot of those patients are infertile. And that's something that is very important. In fact, there is a specific guideline statement related to that issue alone, that testosterone should not be prescribed to men that are seeking fertility. But there are other things, like if you've been treated with chemotherapy, for instance, that can cause fertility as well. There are some genetic causes. Probably the most common genetic cause is something called Klinefelter syndrome. That's where men have an extra X chromosome. It's present in about 1 in 600 men. That can non-obstructive azoospermia, where there's no sperm in the ejaculate. It's one of the most common causes of non-obstructive azoospermia, and that's where we do that micro-TZ. In fact, today I saw 2 patients alone with that condition. There are other genetic conditions as well. There are some environmental causes, such as smoking, drugs, being overweight, chronic alcohol, chronic diseases. And there's a whole raft of causes. And that's why it's important. This, again, one of the other guideline statements is that if you have been diagnosed with having infertility, or there's been some abnormality on your semen test, it's important to be assessed by a specialist in male infertility so they can go through all of these complex causes and try and find which ones can be optimized, which ones can be reversed, and which ones can be treated.
What are the most notable recommendations you have for GPs and doctors?
So some of the most notable recommendations might be even some of the most simple recommendations, Sally. For instance, in the beginning of our discussion today, we mentioned that male infertility affects 1 in 6 couples. And in those 1 in 6 couples, 50% of the time, there's a male factor that is potentially contributing to the couple's infertility. So we know in our experience, and this was echoed time and again in our discussions on the panel of experts, that it's often when a couple is presented with infertility, it's the female partner that's sent off for a whole gamut of tests. And often only after those tests are normal, then the male will be tested. But because this is a couple's issue, and because half the time there's a female issue and half the time it's a male issue, one of the first guideline statements suggests that for the initial consultation and for the initial infertility evaluation, both the male and the female partner should undergo concurrent assessments at the same time. When I do discuss this with my patients, and I've mentioned some of my patients some of these guidelines, and I've said, this is actually one of the first guideline statements that we'll mention out of the 80, right? It's number 2. And I think it was 2 days ago I mentioned this to a couple, and it was the female partner who said, "Doctor, I just want to thank you for doing that. I don't think you can appreciate what we've gone through as a couple. I was put through a whole raft of tests. A lot of them were unnecessary. We wasted like a year of testing, and finally they decided to look at my husband. And it's the problem lies with him. He needs to be fixed. I don't know why this wasn't done earlier." And we see this time and again. So that's one of the first guideline statements. I think one of the most important that GPs can take away. When a couple comes to see you, please test both the male and the female at the same time. And probably the simplest thing to do, and this is another guideline statement, just get a semen analysis. A semen analysis is important. It's often a sort of a window into a man's health as well. But if the semen analysis is abnormal, then another semen analysis done about 6 to 8 weeks later, that's another guideline statement, should be done to confirm whether or not there is persistent abnormality. And if there is, then at that point, the patient should be referred to a male fertility specialist. Another guideline statement suggests that if there is no sperm in the ejaculation fluid, in most men, we can actually find sperm in the testicle by that procedure that I mentioned, that micro-TZ, I mentioned it earlier on in the podcast. So that should not be the end of the line. What I mean by that is that if a patient has a semen analysis and there is no sperm, there's still hope for that patient. There's still hope for that patient can be a biological father. Like I said, I have had in my clinic some patients who were told if there's no sperm in the ejaculation, then there's no hope for them being a father, at least a biological father, and that is just not true. So that's another important guideline statement. There's another guideline statement, another recommendation that says other health issues should be screened for when a patient's infertile. What are some of those tests? What are some of those conditions? You should screen for testicular cancer, low testosterone. We know that there are other health issues that may be a cause or a result of infertility. I mentioned this before as part of the causes, such as chronic illnesses, being overweight. Sperm are very fragile creatures, and they can often be a barometer of a man's health. Another, I mentioned this previously as a very, very important guideline, a statement, a recommendation is to avoid giving testosterone to men who may desire fertility. Okay, very important. When you do take testosterone, sometimes when you stop the testosterone, you have a return of your fertility potential, but sometimes patients don't. It's hard to know which ones, hard to predict which ones may or may not return, but it's very, very important. So any patient who's considering taking testosterone, they need to essentially have completed their fertility journey. As I mentioned beforehand, there's a whole raft of guideline statements and recommendations purely on varicoceles, because as a panel, we thought that was such an important topic, a topic that we believe is underappreciated. For instance, I'll go through one key guideline statement and you'll just see how pervasive and how important a varicocele is. So I'm reading from the guideline statement, which says, consider varicocele treatment in men with infertility who have a clinical varicocele, by that I mean a palpable varicocele, and any of the following. Number one, an abnormal semen parameters. Number two, in patients who may have unexplained infertility. Number three, patients who may have raised sperm DNA fragmentation. Or four, in patients or in couples who have experienced failed IVF or ART, including recurrent pregnancy loss or poor embryo development. So some patients don't appreciate this. In fact, varicoceles can affect the success of the IVF process. Varicoceles can even affect women who are getting recurrent pregnancy loss. So it's a really, really, really important diagnosis to make and treat if necessary. Another guideline statement, which I think needs some highlighting, is, and I'll read this also directly, if a man has had a vasectomy should be considered as a treatment to restore natural fertility. So in our experience, there are some men who, if they have had a vasectomy, they are told that in order to have a child, you need to go through the IVF process. And that's not exactly true. There are some men who can have their fertility potential restored purely by having a vasectomy reversal, even many, many years after the vasectomy has been done. Of course, it's not guaranteed, but certainly our guideline statement suggests that it should at least be considered as part of and weighed up against the pros and cons of IVF. And probably one of the last guideline statements I want to flag is that regarding cancer treatment, and one of the guideline statements recommends that you should consider and always consider sperm storage in men who are about to undergo cancer treatment.
Right. So how will these guidelines impact Australian men?
Because these are the first ever guidelines, I think these will have a profound effect, and I hope they'll have a profound effect in improving how male infertility is managed in Australia to make it as good or even better than anywhere in the world. These guidelines will be freely available, and because they're endorsed by those key stakeholder organisations I mentioned before, then I really hope there'll be widespread uptake of these guidelines. One of the purposes is really to facilitate uniform management for all men suffering from infertility in Australia, and to facilitate coordination between the different practitioners who manage infertility as well. Another purpose of the guidelines is to really raise awareness of this common problem. It's important to try and reduce the stigma of male infertility. I think we can do this by highlighting that this is a common problem which can often be helped and treated. I've actually published on this issue, i.e. when a man is diagnosed with infertility, it's a real hit to a man's masculinity, and it can be a major, major sort of source of stress and a mental health struggle. And for some men, just knowing that it's common, knowing there's something that can be done, can be the first step in helping a man deal with this very sort of emotional and psychologically challenging diagnosis. And I think these guidelines, another sort of aim in these guidelines is really to give men hope. Give men hope that maybe when they were told that there was none, that they can potentially be a biological father. I mean, I've lost count the number of men that have come to see me in my clinic who've been told that there was no hope, but after treatment, their dreams of becoming a father have been realized. And I've got a whole sort of raft of photos on my wall of children behind my desk. Each one of them is just such a special story. And I feel I've got a special connection to each and every one of these children. And these guidelines I really think they're about hope for men and giving them the best chance that they can to be a biological father.
That's lovely. So, I mean, as I said before, we female infertility is well known. Male infertility isn't as much, and this is going to go a long way to changing that. So you touched on it before. Infertility for men is quite an ordeal.
100%. It's an ordeal. And I mean, this podcast is in the afternoon. I just finished consulting. My last consultation was with a couple, and it was half the consultation was just acknowledging the male's mental stress and the ordeal that he's going through, and telling him that it's okay. It's okay to ask for help. In fact, my catchphrase is, this is a sign of strength when you ask for some help, get some counselling. This is a couple's issue. And the partner actually said to me, "Thank you for saying that, doctor. This morning it was me going to the psychologist, but I actually think my husband needs it more than I do," right? And just giving them that permission to say, as a male, this is a common problem. This is a common stress. This is something that can really make you feel that you've lost part of your manhood, and that's okay, right? And that's understandable, and it's important to seek help, and just having that conversation with men is just an important part of their treatment and as part of their fertility journey.
So it must feel good to be able to help these men.
I really do feel privileged, Sally, to have done this subspecialty training to allow me to help these men. I really do. I mean, these are the happiest patients that I have in my clinic. They come in when I see them, sometimes a year or two into their journey when they first come to see me. You can see what they've gone through, the stresses, the tests. They think they can't be helped. They've had these. They've got no sperm in their ejaculation fluid, for instance. And for instance, we do this micro-TZ, and it's not always successful, but, in most patients we can find sperm. And then, a year or two down the track, they walk in with a baby, and they're just beaming. And they've come from being told it's impossible, and then it's just happened. And I can tell you, on both sides of the consultation desk, there's emotions. I invest a lot in my patients. I know how important this is for patients to have children. And although, infertility in some respects, it's a lifestyle condition, not, you don't have to have children. But it's just such an important part of medicine, and to be able to help patients achieve, their dreams and their goals, I really do feel privileged.
That's wonderful. Thank you to my special guest, Associate Professor Darren Katz. You can find more podcasts on our website at mja.com.au or wherever you find your podcasts. Thank you so much for listening.